A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. My dear friends and students of final year Mbbs studying in Pakistan, and this is for you. That is something about the acute breathlessness. The patient comes to you with acute breathlessness. How will you evaluate for this problem? Second one is the chronic breathlessness or intermittent breathlessness. It may be escalating breathlessness, there is nothing, but it is acute breathlessness. So I am Professor Sayyid Ali Haider. I am a visiting professor of Jalal Medical University, and I am trying to clear the concept of the students who are interested to clear themselves. Scenario, true scenario. A 75-year-old lady, she was chemist, had unilateral total knee replacement. 3 days back, when she was choked while in the bed during her feeding. She was choking. Emergency measures were taken and she was shifted to ICU then at once, where the suction was given and afterwards the clinical examination was done, temperature 104. At the time when she was operated, just after the surgery, she has got 101, temperature now raised to 104, pulse is 116 per minute, irregular with low volume pulse, respiratory rate is 38 per minute, very high, with the Shane-Stokes type of the character. And the blood pressure was 74/62, she is in hypertension. Chest full of coarse crepitations, full. Central and the peripheral cyanosis was positive, both positive. Investigation at the time, after 2 hours or 3 hours is event, the hemoglobin is 11.4, TLC was 17.4, previously it was 13.4. The platelet is 1,25,000 and SpO2 pulse oximetry showing 88%. Meaning that is, to this pulse oximetry, this is hypoxia. The X-ray chest was shown and it reveals that there are the multinodular opacities in both lung fields, in the middle zone and the lower zone. These opacities may micro and macronodular mixed type of the opacities, the multiple opacities. Now ECG showed the atrial fibrillation. X-ray chest is given here for this patient, for example. You see this is the position of this trachea. Important negative finding, that is normal. Trachea is shifted not here, it should be here. It is not shifted to either side. Other parameters assumed to be normal. She is osteoporotic as platelet densities are reduced in places. Now, talking about the lung fields are concerned, the upper apical zone with the first intercostal phase, with the first, second with the second, third with the third, fourth with the fourth, fifth with the fifth, sixth with the sixth, seventh, and so on, up till going to the dome of the diaphragm, where the costophrenic angle is obliterated, and costophrenic angle and cardiophrenic angle is also obliterated with these nodular type of opacities. Because she is in 9th position, it is recommended X-ray, because the first, second, third, fourth, and fifth touching here. It is a recommended X-ray or the lying X-ray, therefore we cannot comment on the size of the heart and upper part of the medial mediastinum. And the hilar nodes, they are prominent one. They are not enlarged, but they are prominent. So mixed micronervular and the macronervular opacities, and from upside down it is increasing. It is called towering sign. Towering sign, that is called. The tower, you look the tower, right towers, the upwards it is, and then going downwards. Upper one is very, very clear. The light is going on. Low down, you go. They are darkening and darkening and darkening. Now, electrocardiography will show here there is sinus tachycardia, no doubt about it. And the important thing about this electrocardiograph is that the rhythm, look the rhythm. It is irregular. The RR duration varies, and there is no P wave in any lead of this ECG. It is fast, or quick, or a sprint type of the atrial fibrillation. So it is the atrial fibrillation with high ventricular rate. This is the inference. I don't want to discuss in detail about the electrocardiogram to save my time. Question is, what is the differential diagnosis? Although history was very, very clear. But how will you further investigate if you want to do? What is the most probable diagnosis? And how will you manage 4 parts of any scenario? You have to answer in your life. Whole life, you have to answer this question. Direct soft data from this scenario is old lady, history of recent surgery, with fever, hemoglobin is 11.4, platelet was 1,25,000. Soft data because it will not help you specific diagnosis. Rather than the hard data, acute presentation, within minutes to hour, 1 hour, within minutes to hour, she has got the severe breathlessness, attack of the severe breathlessness. The history of the recent knee surgery, there was a history of choking. She was clinically in respiratory distress. She was in ICU patient, and high pulse evidence of atrial fibrillation, and respiratory rate is increased with Shane stroke pattern, cyanosis, hypertension, coarse capitation in the lung, hypoxemia in the pulse oximetry, and X-ray showed the nodal opacities, multiple in the lung fields from above downwards, and ECG evidence of the atrial fibrillation. Stop here. If third-year students are here with me, for example, and they are also watching this video, then it is very helpful to them in their future. First describe these terminologies and then choose one diagnosis from them. Respiratory depression, apnea, hyperapnea, tachypnea, tapapnea, platypnea, orthopnea, type 1 respiratory failure, type 2 respiratory failure, acute lung injury, ALI, and acute respiratory depression syndrome, ARDS. These are the terminologies which we are using here in most of our cases with acute breathlessness or mounting breathlessness, whatever it is. These terminologies should be cleared. Respiratory depression is that in medicine, the hypoventilation, also known as respiratory depression, the same thing. Hypoventilation occurs when the inspiration, ventilation, inspiration, expiration is inadequate. Hypo means below to perform the needed gas exchange. By definition, it causes an increased concentration because carbon dioxide is not removed properly. There is hypercapnia, and they will be associated retention of the carbonic acid in the blood, and the pH will decrease, causing the respiratory acidosis. It will be compensated by metabolic type of alkalosis. Otherwise, patient will die. Apnea or apnea in suspension, both of breathing. During apnea, there is no movement of the muscles of inhalation, and the volume of the lungs and initially remain unchanged. Still quite, depending on the how blocked the airways are patent, how many blocked airways are patent, there may or may not be a flow of gas between the lungs and the environment for a few seconds rather, or a few minutes rather. The gas exchange within the lungs and the cellular respiration is not affected. The gas exchange is concerning, definitely it is reduced. Oxygen concentration will be reduced and the retention of the carbon dioxide will be there. Apnea occurs actually in attacks. There may be predisposing cause of the apnea. Apneic attacks in the children are common. Breath holding attacks are common in the children. This is the terminology NEA, apnea. No evidence of respiration for a few seconds to a minute. You cannot hold more than that. The patient will die, definitely, because it is essential life organ, lungs. The hyperapnea means that increase the depth of breathing, which may or may not be accompanied by the increase in the respiratory rate. You take the deep breath, deepness of the inspiration is hyperapnea. Maximal hyperapnea occurs during strenuous exercise. If you do, you have to suck the air inside. Although the rate of respiratory rate may be normal. So hyperapnea mainly it is associated with the high rate of respiration. That is called tachypnea, is the condition that causes the rapid and shallow breathing due to an imbalance between the carbon dioxide and oxygen in the body. Because reflex arc will be produced, the efferent arc, the efferent arc, and tachypnea occurs for the compensation. So hyperapnea and tachypnea. Tachypnea is the terminology we use, is the shortness of the breath that is sensed while lying on one side, lateral side, but not on the other side, lateral recumbent position. It results in the disease of the lung, one lung which is affected, one major bronchus which is affected, or either the chronic congestive cardiac failure, CCF. The tachypnea may occur in these conditions. There is, of course, one lung is affected by pneumothorax or whatever, or pleural effusion, massive, or one major bronchus is gone, major principal bronchus is gone by blockage or something else. Atelectasis occurs, and because of atelectasis, and there will be tachypnea. Or in cases of the CCF, tachypnea is the marker associated with another terminology that is platypnea. The platypnea or the platypnea is a shortness of the breath that is revealed when lying down. When lying down, relieved on lying down, and worsens, that is opposite, while he wants to sit or standing. Platypnea is due to either the hepatopulmonary syndrome. That is very, very important. I asked the question of a candidate at CPS medicine, what are the causes of platypnea? He said that the diaphragmatic illnesses, it is illness of the diaphragm which causes. But the major thing which you want to understand should be hepatopulmonary syndrome. Here is the cardiovascular defect, increasing the positional, there will be right to the left shunting of the blood. All conditions in which there is a right to the left shunting of the blood, there will be platypnea. That is as simple as that. Right to the left. Not from the left to the right. It is right to the left. These defects include the rare syndromes in which the venous blood from the blood overpasses the lungs, or if the venous blood from the portal circulation directly communicates with the inferior vena cava without passing through the liver, it means in the cirrhotic liver, because all is parenchyma is gone, then the portal circulation have to reach the inferior vena cava. But the liver is not functioning, therefore it is connected directly with the inferior vena cava by passing it. In these conditions, there will be platypnea. So in cases of the, what we call in our terminology, it is hepatic encephalopathy. In cases of hepatorenal syndrome or hepatopulmonary syndrome, we will see platypnea. Patient is relieved on sitting rather than on lying. Orthopnea means a shortness of the breath that occurs with lying down, it is opposite to the platypnea, and is relieved by propped up in the bed or sitting in the chair. It is one of the most important markers of the heart failure or acute pulmonary or progressive pulmonary edema. Respiratory failure is decompensation of the respiratory function to meet the metabolic demands of the body. This can be from the failure of the tissue oxygenation or the failure of the carbon dioxide homeostasis. So this is what happening in the respiratory failure. The exchange of the gases is not doing on the correct path. Oxygen is not going inside the blood, hypoxia. Carbon dioxide either is normal or there is a retention of carbon dioxide. A disturbance of the oxygen disposition curve there. It means that the respiratory failure this is the terminology which we use. Type 1 respiratory failure, important thing in this is the hypoxia and with the normal carbon dioxide. Carbon dioxide in the blood, there will be no change in the PCO2. PO2 levels will be decreased. But in the second one, the type 2 respiratory failure, there will be hypoxia and there will be retention of the carbon dioxide. That is called hypercapnia. Hypercapnia associated with the hypoxia is type 2 respiratory failure. There is comparison which is given as the type respiratory 1 and type 2 respiratory failure. Type 1 may be acute chronic, type 2 may be acute or chronic. In acute type 1, the PO2 levels are markedly decreased, PSO2 is normal and maybe low down, and pH is normal because it is acute condition, or it may be lower down. It means that the respiratory acidosis, and it will be compensated with the bicarbonate then. It will be respiratory acidosis compensating by the bicarbonate. While in the chronic, the PSO2 level are reduced but not much higher, lower levels. PSO2 is normal, is a type 1, normal, pH is normal, bicarbonate is normal. Only in the acute condition there will be disturbance there. Otherwise, the chronic progressive one, only the PA2 levels are reduced. The causes of the acute one, type 1, asthma, pulmonary embolism, pulmonary edema, ARDS, pneumothorax, pneumonia, where the capacity of the lungs are reduced very, very quickly. And chronic progressive emphysema, lung fibrosis, lymphangitis carcinomatosa, right to the left shunt of the blood in the circulatory system, and the anemia, severe anemia, can cause the type 2 or 1 chronic respiratory failure. Therapy is to treat the underlying cause, high concentration oxygen, mechanical ventilation because acute condition. While in the chronic one, the treatment underlying disorder, long-term at-home oxygenation is the main therapy of this condition. Type 2 respiratory failure, where the PO2 level is less than 80 millimeter and the PSO2 level is more than 45. Normally it is about 30 to 45. It is increased 45 to 45, more than that. Acute condition, blood gases or PO2 level will be decreased, PCO2 levels are normal, pH is reduced usually, and bicarbonates are compensating because of the respiratory acidosis. The chronic one, because it's progressive, it is PO2 levels are reduced, PCO2 level may be or should be raised rather. Because retention occurs, the pH will be reduced because of respiratory acidosis in most of the cases, while bicarbonates are compensating by increasing. That is metabolic alkalosis. It is compensated by the metabolic alkalosis. The etiology of the type 2 acute failure is the severe acute asthma, acute epiglottitis, inhaled foreign body, respiratory muscle paralysis, frail chest injuries, sleep apnea, brainstem lesion. Narcotic drugs will depress the centers, respiratory center, which is lying in the brainstem. Now, treat in this condition, in the chronic progressive type of the type 2 respiratory failure, the major illness is COPD, and it is the polar end, which is chronic bronchitis. Primary alveolar type of hypoventilation. Primary means idiopathic. Kyphoscoliosis, ankylosing spondylitis, causing the restricted movements of the chest wall. Kyphoscoliosis reduced, rickets, painful inspiration and expiration, and severe osteomalacia will also cause this retention of the carbon dioxide. The treatment of type acute one, underlying disorder, you have to go for the mechanical ventilation, and PEEP is the more positive and expiratory pressure is the mode of mechanical ventilation. Or if it is foreign body or acute epiglottitis, then tracheostomy should be done. And in the chronic progressive type of type 2 respiratory failure, treat the underlying disorder, COPD, whatever it is, and control with the long-term oxygenation intermittent. Only mechanical ventilation is needed when there is severe disease, when the PO2 level is markedly reduced and carbon dioxide retention is very high. Then you need the definitely aggressive therapy. Now coming to this, please try to understand what is this terminology. FiO2 means the fraction of oxygen in the inspired air. FiO2 is calculated by 20% plus 4 multiplied by oxygen liter flow. For example, you are given 2 liters per minute. The 2 for the 8, it means that 4 to the 8, it should be with 20% FiO2. 20 means 20%. To 20% means whatever it is, it should be converted into the numbers just like this. And breath rate, how slow or fast the person is breathing, inspiratory flow rate, affected by both the breath rate and the breath size, rate and the effort with the breathing. It depends upon this. The FiO2 is very important terminology. Please try to remember this fraction of oxygen in the inspired air. If you can remember the formula, that is all right. Otherwise, you can calculate it. The F represents the FiO2, the fraction percentage inspired oxygen that patient is receiving, expressed as a decimal, that is 40% oxygen, is equivalent to the FiO2 of 0.40. This is the formulation, a chart. 40% oxygen at the rate of the 2 per minute, for example, the FiO2 will be 0.40. Then the P, which is divided by F, P divided by the F. F is already calculated. P means the partial pressure of oxygen to the FiO2 ratio. Example is that in this case is the PO2 is 90 on the 40% oxygen, which is 90, and is equivalent to FiO2 of 0.40. So 90 divided by 0.40 is 225. Ratio is 225. So ratio varies in the different type of the diseases of the respiratory tract from 100 to 400. Ratio is very important. If you calculate the ratio, then you can understand the problems which is now coming. Now flow rate, liter per minute, 1 liter per minute, 0.24 FiO2, with 2, with 3, with 4, with 5, with 6. Just divide it, this FiO2, with the partial pressure of oxygen. You can calculate the ratio. Acute lung injury, that is why I have told you the terminology should be, you should understand the terminology. The acute lung injury is a common condition that is characterized by acute severe hypoxia, very severe. That is not due to the left atrial hypertension. So it is not due to the cardiac problem. There is something else that is going on, damage to the lung. Very quickly, the ratio of the PO2 to FiO2, which I just mentioned previously, should be more than 300. You diagnose this condition on this base, the ratio. Because another terminology which is coming is ARDS, acute respiratory distress syndrome, or at one time it is called idiopathic respiratory distress syndrome. It is a medical condition occurring in the critically ill patients. It will be characterized by the widest spread inflammation in the lung, very quick time. The ARDS is not a particular disease, it is a result of the disease. It is a clinical phenotype which will be triggered by the various pathologies such as trauma and burns and pneumonia, sepsis, septicemia, pyemia, etc., etc. But the important thing is diagnosis, because it is acute lung injury or ARDS. The ARDS, the ratio of the PO2 to FiO2 should be less than 200. And acute lung injury is more than 300. Here it is less than 200. The difference, remember the difference between the ALI, acute lung injury, to ARDS. The causes of the acute breathlessness, select from below. The cardiovascular system, acute dyspnea, chronic exertional dyspnea. In acute pulmonary edema, chronic congestive cardiac failure, myocardial ischemia. Respiratory system, acute severe asthma, acute exacerbation of COPD, pneumothorax, pulmonary embolism, ARDS, pneumonia, lobar collapse, inhaled foreign body, acute epiglottitis, laryngeal edema. It means that others are metabolic acidosis and hyperventilation or acute dyspnea. The system involving, accordingly, cardiovascular system can cause respiratory system and other systems can be involved. It may be central type of the dyspnea, psychiatric problems. Chronic exertional dyspnea, chronic congestive cardiac failure, myocardial ischemia, COPD, and chronic asthma, respiratory system is involving. Chronic pulmonary thromboembolism, large pleural effusion, large pneumothorax, bronchial carcinoma, lymphatic carcinomatosis. Now, ILD, interstitial lung disease like sarcoidosis, fibrotic enteritis, extrinsic allergic rhinitis, pneumoconiosis, where the interstitium of the lung is gone. So the pressurizing on the venous side and the arterial side. And the other conditions like hematologically severe anemia can cause because the oxygen carrying capacity is low. And in obesity, because of the muscles are not functioning well, the obesity associated with the dyspnea, Pickwickian syndrome, for example, that is the obesity hypoventilation syndrome. That is called Pickwickian syndrome. So these are the causes of the acute breathlessness, and you have to select from the below. Again, I have previously said the different terminologies I have used Select from that. Now select from this also. The patient was in acute dyspnea, yes, in this patient, which I am discussing. So what we saw, terminologies are using respiratory depression and platypnea. She has the platypnea, she has hyperapnea, she has tachypnea, and going downwards, the different terminologies, reaching towards the final diagnosis by calculating the all parameters, the blood gases, the X-rays, the ECG, and on hand possibly the pulmonary function test is possible, do it, and ABGs. In ABGs you will also calculate the ratio between the PO2 and FiO2. If it is like this, then diagnosis is clear. In this condition, the ratio was less than 200, acute respiratory distress syndrome. After all, it is calculated from these definitions. This is ARDS. It may be acute lung injury, but the ratio was less than 200. On the basis of this, the diagnosis was made as ARDS. Essential of diagnosis, according to these in conferences on the acute type of the problems with the respiratory system, acute onset ratio of the partial pressure of the oxygen, the Fi2 of 200 or less than that, should be, regardless of the positive and expected pressure. You do the PEEP on ventilation, but it will definitely be very difficult to increase it. Bilateral infiltrate seen on the chest radiograph, which you have seen, and the pulmonary artery wedge pressure is 18 millimeter or less when measured. It means there is no relation with the left atrial hypertension. So there is no back pressure. Should be excluded by Swan-Ganz catheter, and you will take the pulmonary artery wedge pressure. 18 millimeter is very normal pressure. It is rather low. It is an acute lung injury. It is a part of it. It is a non-cardiogenic pulmonary edema and severe hypoxia associated with this. So it is a non-cardiogenic pulmonary edema and the severe hypoxia. It is a part of the acute lung injury syndromes. A common condition with a complex pathophysiology, very complex. It frequently occurs in critically ill patients. So there will be, of course, the diagnostic criteria as already mentioned. Acute onset, the ratio should be less than 200, bilated pulmonary infiltrates. If it is more than, for less of severe acute lung injury, it is less than 300. It is very severe injuries. It may be more than 200, like this. That's why I have written this. So no evidence of the left ventricular failure should be excluded before diagnosing. The cause of the ARDS already mentioned out previously, although direct lung injury, pneumonia, aspiration of the gastric contents, pulmonary contusion, fat embolism, inhalation injury, near drowning, and deperfusion pulmonary edema. Now in this case, the aspiration of the gastric contents was the initiating cause of the direct lung injury. Indirect lung injury, sepsis, multiple trauma, accidents, multiple blood transfusion, cardiopulmonary bypass surgery afterwards, can cause burns, acute pancreatitis, drug overdosage, and snake bite poisonings, for example, etc., or poisonings. Other than that, that is called envenomation. In this case, which I am discussing, is the aspiration of the gastric content leading towards the acute type of the lung injury, and according to the definition, it is ARDS. Histopathology changes, all inflammatory exudates are shown here. Damage, alveolar damage, diffuse damage of the alveoli associated with the all inflammatory cell infiltration in the multiple sites in the lung. Pathogenesis, I already told you about it. I don't want to discuss in detail about the pathogenesis is concerned. And the clinical findings already told you about it. It is tachypnea and tachycardia, respiratory, alcoholism because carbon dioxide is out, compensated by the metabolic acidosis, and so on. And these are the clinical findings already mentioned out in my case discussion. Chest X-rays, macronodal multiple opacities are very important, and it is seen in this X-ray. The treatment that remove the primary cause if it is necessary. If you found it, remove the primary cause. If it is not possible, then go for the ICU, strict management with ICU. If the PO2 levels are very reduced and SpO2 are very much reduced, and there is evidence of the respiratory acidosis or alkalosis, you do the one thing is possible in this condition, go to the ventilation procedures, mechanical ventilation. And you go for the other things like the antibiotics, very high dosages, and multiple antibiotics are used because the gastric contents contain different type of the bacteria which are commensal to the area of the GIT, but they are not commensal to the lung. The gram positive, gram negative, and you have to cover the anaerobic bacteria. You can minimize the complication, rise, nosocomial infection, because patient is lying for maybe 2 weeks, 3 weeks, and thromboembolism and stress ulcer prophylaxis should be indicated. Nutritional requirement should be fulfilled properly. Diet images. And they said the investigation of the surfactant in neonates with the infant respiratory syndrome, that is IRDS, has led to improved survival rates. A study was done. But in introduction of the surfactant to the adult does not prove that it is beneficial. Lessen the duration of mechanical ventilation and decrease mortality. No. In children, it may be beneficial. Steroids, controversial, should be considered in the late fibrotic phase because it will anti-fibrotic effect. It can be used to combat the fibrotic reaction. Mechanical ventilation, of course, it should be done. And limiting the plateau pressure results in 22% reduction in mortality if you do correctly the mechanical ventilation. Another claim was done that proning the patient can lead to the improvement in oxygenation, possibly by reducing edema and atelectasis in the posterior dependent lung, thereby improving the ventilation perfusion mismatch. It is possible. The failed to decrease mortality, although it will improve the condition, but mortality will not be decreased. But prone positioning may be beneficial. This is a prone position. This is the position of the patient. The conclusion is that extremely demanding therapy, and most patients who have survived from ARDS have permanent mild to moderate impairment of the lung function. And that lady suffered a lot of problems afterwards, which I have discussed. Fibrotic reaction occurred in the lung. She developed interstitial lung disease. She has the past history of the chronic asthma. The lungs are badly affected in her case. Quality of the life after hospitalization with ARDS may be poorer. That is similar. I will suggest the bronchodilation. I will suggest the flu and the pneumococcal seasonal vaccination. I will suggest the good diet. I will suggest the physical therapy. I will suggest for the intermittent oxygenation after the discharge. Thank you for listening this lecture, although it is boring lecture, but it is informative. Inshallah, we will meet it again. Assalamu alaikum wa rahmatullahi.